Medical Center in Boston and oversee the child psychiatric training program there. She's also assistant professor in Tufts Medical Center. Her major interests include anxiety disorder and trauma in children and adolescents. She also has special interest in training and education of child psychiatric fellows, as well as interest in global mental health. So we are very fortunate to have Dr. Neha with us in these late hours in U.S. So thank you, Dr. Neha, and all yours.
Thank you, Dr. Azim. I feel privileged to be able to give this lecture, so thank you everybody for inviting me. I would like to also, since the topic is childhood trauma, I want to give some credit to my associate, Dr. Jing Bu, who helped me put these slides together, but she will not be speaking today, but I wanted to at least give her the credit. So the outline for the following lecture is I'll start with the definition of trauma because I think it can be quite variable. Also, I would like to talk about different types of trauma, the prevalence of trauma, risk factors, some of the neurobiological factors of trauma, how trauma affects a child, how to consider when it is just an adjustment disorder versus a post-traumatic stress disorder, and then how to screen for trauma and some of the considerations for treatment. But I really hope that since trauma is a very huge subject and 45 minutes could be quite limited for such a broad subject, I do hope that you can take some pearls away with you today. I'm hoping that by the end of this lecture, you'll be able to describe how children with traumatic experience can present in your office. I hope that you can understand how trauma impacts development and how you can screen for childhood trauma and at least have a basic understanding of model of treatment to support your patients. So to start, let's start with the definition. What is trauma? A trauma is an event that threatens an injury, death, or the physical integrity of self or others and causes horror, terror, or helplessness at the time of occurrence. But for childhood trauma, it is imperative to understand that the threat does not have to be to self. It can also be to the loved ones. So a child who has observed his mom and dad be beaten, that would be enough to qualify for trauma. And if the child is scared for the livelihood of the parents, that in itself could be sufficient to qualify for trauma. There are different types of trauma. So when I use the term trauma, it's quite a broad term, but these are some of the ways that traumatic experience can look like. It could be physical abuse, it could be sexual abuse, it could be emotional abuse, it could be neglect. So when a child does not get appropriate caretaker as a baby or as a toddler. When there's an exposure to domestic violence, community violence, and school violence, that's also considered to be a type of a trauma. A child who's admitted to hospital multiple times and has multiple procedures, the whole idea of procedures and how threatening it is, how helpless a child may feel, that could be a type of a trauma. So it doesn't need to be what we normally think of trauma. It could be just a sense of helplessness and powerlessness. A loss could be traumatic. So for example, a child's pet, a dog, or a parrot that died suddenly, that could be traumatic as well. Again, what we call clinically post-traumatic stress disorder is different than the trauma experience. So trauma itself is quite broad, and I think we all experience it in many forms throughout the day. But I'm hoping that today I can reflect with you are the specific ways that it can actually impact children negatively. Just to go ahead with the different types of trauma, I also like to mention there's natural disasters, so hurricanes, storms, these can all be part of trauma. Some of the human-made disasters such as warfare experiences and so on. But what is important to remember is the exposure of trauma. There are three different levels of exposure. One is acute trauma, which is a single traumatic event. So for example, an auto accident or a natural disaster. Those tend to be more of the acute trauma. It's a one-time event and it happened and then it ends. Chronic trauma, by definition, is repetitive, which means that it persists for quite a while. So this could be a chronic sexual or physical abuse, so a child who's been abused since they were 3 to 8. It could be emotional trauma, and so on. So a kid who's been bullied for the whole grade, that could be considered a chronic trauma. When I say bullied, I mean bullied in school throughout their class for the whole year, academic year. Complex trauma is a special term that's used by experts in the field, and it refers to people who have chronic trauma, but that's specifically inflicted by parents or people who are supposed to take care of the child. So it kind of mixes with attachment issues, because a person who's supposed to be protecting the child, when they start inflicting trauma to the child, that may result in how the kid sees the world. So it's not just typical signs of PTSD, they become actually quite variable, and they tend to have a lot more comorbidities. So that's considered to be complex trauma. Whenever I do a talk, I always like to talk about why is it important for us to learn this? And so in that regard, I would like to talk about a study, which is called the Adverse Childhood Experiences Study. Now, this study was done in U.S., so I realize that there may be a bias when we're looking at the population, but the numbers are quite drastic, and the purpose of me bringing up this study is to really get you guys to think about how many of our children can be impacted by trauma that we are not aware of. So a study is one of the largest investigations that was ever conducted that has tried to associate childhood maltreatment and later life health and well-being. So it really tries to assess for correlations and not necessarily causations, but simply correlations and level of comorbidity or morbidity and mortality that occurs in children who have had childhood maltreatment. The study was done by Centers for Disease Control in U.S. and the Prevention Kaiser Permanente Health Appraisal Clinic in San Diego, California. The initial phase of the study was conducted by Kaiser Permanente from 1995 to 1997, when more than 17,000 participants were included. This is a longitudinal study, so I'm not going to be going into full-fledged all the results and outcomes of the study, but the basic finding of the study was that almost 2/3 of the participants reported at least one adverse childhood experience, and more than 1 of 5 reported 3 or more adverse childhood experiences. And this was directly associated with multitude of health and social problems. So children who were living in poverty, who observed domestic violence, were noted to be more obese and noted to have more health negative outcomes. So this is just to bring about why it is important to actually look at trauma, because it doesn't just affect the emotional health, it affects the physical health as well. Going along with the A study, these were the basic findings in terms of the number of people who've had different types of abuse. So there was 20% of the subjects had sexual abuse, 10% had emotional abuse, 28% had physical abuse, and 25% of the people were neglected, and at least 40%, which is a pretty high percentage, were exposed to family violence. So that's my regard as to why we should learn more about trauma. So how do we look at trauma, and when should we be thinking about whether a child potentially can be experiencing something traumatic? And these are the listed risk factors that actually push a child toward more traumatic experiences. So a child who has low birth weight, physical deformities, chronic illness, essentially a child who needs a lot of caretaking, a child that is very dependent, may result in being abused more. One part is that child is not able to protect themselves, so they become an easy target, but it's also the fact that the caretakers become overwhelmed for having to take care of this child who needs so much support on an ongoing basis. And that frustration can result in a traumatic interaction. If a parent has drug problem, alcohol problem, or a mental health problem such as depression or anxiety or schizophrenia, bipolar, that can result in increased risk factors for traumatic experience for the child as well. If there's a parent who does not have all the support, so a parent who's single or very young, so they are more likely to be easily frustrated or are overwhelmed because of the financial circumstances, that can result in a traumatic interaction between the child and the parent. And similarly, a parent who has low education or has going through a lot of poverty or there's domestic violence, that can result in a risk factor for a child to experiencing trauma. The problem with trauma is the fact that it's a vicious cycle. So a parent who may have experienced maltreatment in their own household during their own childhood don't know how else to be. So they may actually play out the same style of maltreatment towards their children. So if there's a parental history of child maltreatment in the family, that itself is actually a risk factor for trauma for a child as well. Before we go any further, I would like to talk a little bit about the neurobiology of trauma response. So what happens when a child feels threatened, and then how does the brain react? And that's kind of what I want to focus on right now. There are two main parts that we should be focusing on. One is the frontal lobe, and frontal lobe is involved in integration of thinking and feeling and sensing, and also in some ways executing actions. Some part of the frontal lobe is unconscious, and then there are other parts that are actually involved in conscious actions. The part that we will be focusing on today would predominantly be unconscious part. The second component of the trauma response is limbic system, and this determines emotional significance of the sensory input. So when we're talking about limbic system, we're specifically talking about amygdala, which is the emotional center, especially for fear and anxiety. And amygdala receives information and input from thalamus. So thalamus is the information for senses, and when thalamus receives this information and finds it to be very emotionally highly charged, and it could potentially be something that could bring about fear and anxiety, it fast tracks that information to the amygdala. And if that information is recognized as dangerous, then amygdala will initiate a fight or flight response without instruction to the cortex. So the person may not always be consciously aware of these actions. So when we're talking about fight or flight response, what we're really thinking about is how amygdala sends impulses to hypothalamus, which activates two systems. One system is the sympathetic nervous system, so that results in increased heart rate, blood pressure, respiratory rate, sweating, and etc. And the second system is the hypothalamic pituitary adrenal axis, which results in increased norepinephrine, epinephrine, and stress hormones, specifically cortisol that regulates temperature, metabolism, and blood pressure. Essentially, it prepares the body that, hey, in order for it to protect itself, does it need to fight back or does it need to run away from that situation? So another way of looking at this is when the thalamus, which you can see on the left end of the screen, receives a threatening information, it quickly sends out fast pathway to the amygdala. So the purple is the fast pathway, and all the greens are the slow pathway. So they may take time, and in that sense could actually be brought to conscious mind. So the fast pathway is an unconscious process that's going on. And when amygdala confirms that this is a threatening experience, it sends information to hypothalamus, and therefore autonomic nervous system is induced and the endocrine response starts. Hippocampus is another part, which is a memory center that's really important, and we can talk about that in a few slides more. So everything I just said, I've shown it to you in a picture form, and here it is in a written out form, just to process it in a different way. It is a difficult concept, but this is essentially the neurobiological factors of trauma response. One part that the slides, the previous images didn't include was about dissociation. So there are moments when a child is not capable of fighting or flight. And in that sense, that child can actually become psychologically avoidant. So thus the term dissociation. So it's a mental mechanism by which one withdraws attention from the outside world and focuses on the inner world. The intensity of dissociation varies depending on the intensity and duration of the traumatic event. It can present itself in different forms. So one form is derealization. So it's almost like as if the traumatic event was like a dream, not necessarily a good dream, a horrible negative dream, but it feels like it was surreal. It never really happened. Another form of dissociation is depersonalization, meaning that the person feels like they were not in their own body. It didn't exactly happen to them. They watched it happen to somebody. So it's a bit of an outer body experience, and that's part of one form of dissociation. There's also dissociative amnesia. So this is the moments when the people may not actually have any memory of the traumatic event at all because it's so intolerable to their ego strength. And then there's dissociative fugue, where they actually may block out a period of time and they do not know what they did during that period of time, and they just find themselves in another setting, another time, or another place and not know how they got there. So dissociative amnesia and dissociative fugue can be seen as actually on the same spectrum. And dissociative fugue is an extreme version of dissociative amnesia and lasts longer and is more pervasive. Earlier, I kind of mentioned what hippocampus is involved in. It's involved in a memory center, but I want to talk about how there's actually different types of trauma memory. A traumatic event can play itself out in a child's mind over and over again, and it impacts different types of memory. So one is a cognitive memory, which is more involved with the cortex. This is where who was involved in the traumatic experience, what was involved, where it was, and when it happened. So it's basic, very concrete information. Limbic system is more involved in the emotional memory. So this has more to do with the feelings, the fearfulness, helplessness, powerlessness, and sadness. Midbrain and cerebellum is involved in the more motor and vestibular memory, so such as the body position. So often, for example, a child who has been raped, when another person touches them similarly and the motor vestibular memory is triggered, that can actually result in them having a flashback. So that's how motor vestibular memory can be involved. Brainstem is involved in a state memory. So this is a level of arousal, since brainstem is known for being involved in alertness of ourselves. This is where how awake or anxious or arousal state we were in, that's what this memory remembers and can get triggered. So re-exposure to any of the cues of any of these memories associated with the trauma can elicit the stored quote-unquote memories and the signs and symptoms of post-traumatic stress disorder. Now, I would like to move along to how trauma impacts a child and how it can impact development. It can impair a child's ability to function in many different ways. Some of that depends on what type of trauma it is, so referring to whether it's an acute trauma, chronic trauma, or complex trauma, how severe it is, so how deeply it may have impacted that child at that moment when it actually happened, at the age of the trauma. So if a child is very young and was neglected, that traumatic experience may have impacted the development of the brain at such an early age that it may be much more difficult to change that neurobiological connectivity. The duration of the trauma, so if it was something that happened few times versus that happened pervasively every day, whether it happened in a predictable time setting versus unpredictable time setting, all of that impacts how a child can be impaired. And of course, it's not just the actual traumatic experience, it's also how the environment responds to that traumatic experience and how the child was taken out of that situation, how we respond, how we protect the child. All of these things result in an impact and level of impairment the child can experience. So specifically talking about the brain development and how trauma can impact brain development, I would like to talk about the prefrontal limbic pathway. This pathway is known to be mature depending on the experiences. So it's very dependent on the external environment to a great extent, and this is where nature and nurture kind of have a little bit of a play. There's been enough studies that show that there's been a significant amount of deficit in brain volume, gray and white matter of the prefrontal limbic system on the neuroimaging studies. So there's something that's actually happening in this area when a person experiences traumatic experience. There's diffusion tensor imaging studies that show that there's a structural interregional connectivity, has a bit of a loss and has deficits in this specific area. And then there's also functional imaging studies that show atypical activation in these brain regions during response, inhibition, working memory, and emotion processing in traumatized individuals. So trauma has a deep brain developmental impact, and that's one of the reasons why we need to address this very rigorously. Trauma also impacts attachment. It often has a lot to do with the caregivers who are supposed to provide protection and safety, and when they're unable to, and when they become the source of harm and feeling of helplessness and abandonment, the child's world becomes extremely uncertain and unpredictable, essentially because child relies on the parents to understand the world, and when the parent is not reliable and instead hurting the child, that world becomes quite incomprehensible and chaotic for the child. And that results in their ability to form relations, to regulate their emotions, to manage stress, to trust others, to be able to make connections with people. Thus, when a caregiver has been harmful to a child, that attachment between the child and that caregiver, it results in non-secure attachment. So there are many different types of attachments, but it can be more than one type, but it will definitely not be secure attachment. I alluded to how trauma may impact emotional regulation. And so I want to take a minute to go a little bit more into it. It is important for a child to learn how to identify experiences and emotions, internal states, and be able to express it. When a child is traumatized, all of that may be taken away from them, especially when that's happening in a chronic situation. And if there's a lack of modeling in the environment about how to regulate your emotions, then this child may actually not know how to understand their own emotions. And so they may react in quite variable ways. So they may appear quiet, withdrawn, unexpressive, or they may actually become very angry and be aggressive. So in either case, they become very emotionally dysregulated. This dysregulation doesn't just stay to emotions, it actually also extends to behavior. So children may present with problematic behavior, for example, in aggression, self-injurious behaviors, or sexualized behaviors if they were sexually abused. Some of these behaviors may have been survival adaptations to overwhelming stress, but because children may not always be able to predict when the traumatic experience happened, they may generalize these behaviors to all times. So they may be behaving in an aggressive way at school where nobody's trying to hurt them, but they don't know when to stop behaving this way, when to be in the fight and flight mode, and when to be in a calm place. So their inability to predict when it is safe and when it is not may result in large amount of behavioral dysregulation. Trauma deeply also impacts cognition. I'm sorry, I think there's a typo there. I meant to write learning and school performance, so please correct that on your slides. So the way trauma impacts brain development, it may actually limit the ability for the child to concentrate. And if the child is not concentrating, they're simply not learning. If the child is not able to regulate themselves emotionally, internally, it's hard to focus outside and think about what is the environment has to teach me. All the books seem immaterial. So it is important to know that when a child is not feeling safe, they may present as if they have language delay, and it also may impact their language development in a neurobiological way. So this is one of the ways chronic high cortisol level can impact the brain. It can actually prevent development of different parts of the brain, thus resulting in delays in language development, deficits in overall IQ, difficulty concentrating and learning problems, difficulty in completing tasks, inability to anticipate and prepare for future events. And this is the reason why a lot of kids with trauma actually look like ADHD kids. And it is important that when we're assessing kids for ADHD, or they're not responding to stimulants and not responding to behavioral measures, we need to reassess whether there's something traumatic going on as well. So needless to say, children with traumatic experiences are at risk for low academic performance, school dropout, and potentially later employment problems. Similarly, it's not a surprise that trauma impacts a person's sense of self. If a child feels that they're powerless, helpless, that the world around them is unpredictable, and they don't know how to protect themselves, they start feeling ineffective in their world. They start feeling helpless, they feel deficient, and they feel unlovable because all of these bad things are happening to them. So the only way they make sense out of this is by saying that, well, something must be wrong with me. I must not be somebody who's worthy of love. And so it deeply impacts their understanding of themselves and how they think of themselves. So kids may actually blame themselves for the traumatic experiences that they had. It's not uncommon for a lot of rape victims to actually feel that they must have done something wrong for them to be raped. And then they use that powerlessness to actually feel a sense of shame and guilt and blame themselves. So this is the deeper impact of trauma, and in some ways the hardest part to treat. Trauma also impacts social development. As I've alluded before, it impacts one's ability to trust their environment. So when they cannot trust their environment, it's hard to develop social skills. When you can't say that my friend is actually going to stay my friend, and you cannot let go of all of your reservations, it's hard to form healthy relationships. So these children are more likely to actually be socially isolated, and then thus they don't develop social skills as well. So I think as of yet, we've been able to talk a lot about, the neurobiological factors of trauma, the fight and flight mode, different ways trauma can impact a child. Now I would like to start thinking a little bit more about the clinical presentations. But before I continue with the clinical presentation, it's important to know what it can look like. And the way I look at trauma is like the great masquerader of psychiatry. And in that sense, it's kind of like syphilis, except in psychiatry. So it can look like depression, it can look like anxiety. When kids are dissociated, they can look psychotic. It can contribute to substance abuse. So kids who've been traumatized, who feel unsafe, they may try to numb themselves by using drugs. So it's easy to say that they have drug problems when they actually may have trauma as well. These kids, because they feel that they can't control anything, often may try to control their diet, and so they can develop eating disorders. They can become very self-rejecting and self-hating, so they may actually want to eat less because they feel like they're not deserving of love. So this may be maladaptive way of reacting to traumatic experience. They may develop a lot of behavioral issues, and this is often the main reason why we end up seeing children. As I mentioned earlier, since trauma impacts brain development and IQ and cognition, these kids can present with intellectual disability. And sad thing is that kids with intellectual disability, because they're dependent, actually already have a risk factor to be traumatized. So it can easily become a bit of a vicious cycle. A lot of kids with ADHD actually have trauma because trauma can easily, the little dissociations can look like inattention. The behavioral issues of trauma can look like hyperactivity. So it is really, really important to differentiate between ADHD and trauma. There's a long list of comorbidities and differential diagnosis between trauma and other mental health conditions, but this is the short list that I figured I should at least mention, but there's a long list that, because of time constraints, I will not be able to go into. So moving along with the clinical presentation, I just wanted to talk a little bit about the DSM-5, the new diagnostic standard manual about PTSD symptoms. There's been some changes in the criteria for PTSD symptoms. Previously, we had 3 clusters. Now we have 4 clusters. But there's also been some additions. So preschool subtype is another class of, or subtype of trauma that has been involved in DSM-5. Preschool subtype is specific for age group age 6 and less. So I just want you to know, so that's specifically for younger kids, age 6 and less. But overall, the main clusters are similar. So the 4 clusters are re-experiencing, avoidance, negative thoughts, or mood, and hyperarousal. When we're talking about re-experiencing, we're talking about intrusive recollections. So this is where a child may not trying to be thinking about the traumatic event, but those thoughts intrude in their mind. So they feel like they're coming from outside, and the child feels powerless and unable to control those thoughts. There's also, they may experience nightmares, flashbacks, physical and emotional distress. And the physical and emotional distress is more in severity than the typical age group. For a preschool subtype and for the re-experiencing cluster, they may actually present some of these symptoms by repetitive play. Children are often, not just children actually, all of us are often trying to make meaning out of our experience. So when a traumatic event happens, we may ruminate over it to understand it better. And so the way a preschooler may show that is by repetitive play. So they may use the same scene over and over again to understand their situation better. So that's one way re-experiencing may present itself in a preschooler. To move along to the avoidance cluster, there are 2 components of it. There's the internal reminder and then there's external reminder. When we're talking about the internal reminder, we're talking about the thoughts and the feelings. And this is where sometimes people may use drugs and alcohol to numb themselves out, so they're not actually having those internal, they're kind of avoiding their internal experience. Similarly, they may try to avoid external reminders, so such as the area that they were traumatized in, or the person who may have traumatized them, or anybody who looks like that person, they may be avoiding that. So the idea is that they may avoid internal or external reminders, but at least one of the 2 to make the criteria of PTSD. Third cluster is negative thoughts or mood. So for example, distorted concept of self, dissociative amnesia, distorted blame of self or others, persistent fear, diminished pleasure in things that they used to enjoy prior to the traumatic experience, sense of detachment, sense of like they're not connecting with their society and their community, and having constructed affect. So they need to have at least 2 of these 7 symptoms for PTSD. However, when it comes to the preschool subtype, either the avoidant or negative thought or mood can be positive. So it doesn't have to be both. It could be one of the 2. Typically, preschoolers do not show amnesia. They do not have that shortened sense of future. They may not have a persistent blame of self or others. So those are not typically found in preschoolers. But they may show some of the other signs. But again, they have to be positive for only one of the 2 clusters. Hyperarousal is the 4th cluster. In this cluster, the child may be more irritable. There may be a lot more self-destructive behavior. They may be hypervigilant, have exaggerated startled response. So a little knock on the door may startle the child. These children will have a lot of sleep problems, difficulty with concentration, and at least 2 of these symptoms would have to be positive. For preschooler, there would have to be 2 out of 5 because self-destructive behaviors do not typically present in preschoolers. So we're expecting the same level of hyperarousal, but just not expecting one of the symptoms. So to diagnose kids with post-traumatic stress disorder or preschool subtype, we have these 4 clusters that need to be positive. I've stated the number of symptoms that have to be present for each cluster. And then for PTSD, these symptoms have to be present for at least over a month. And if it's been present for less than 3 months, that's called acute PTSD. And if it's been present for more than 3 months, then it's chronic PTSD. When these symptoms are present for less than a month, then that's called acute stress disorder. So similar criteria applies, but that would be acute stress disorder. More than a month is PTSD. And then if a child is a preschooler but has these symptoms for their more than a month, then that's called preschool subtype. There's another subtype which is called dissociative subtype. As I have mentioned before, dissociation by definition is a subjective sense of numbing, detachment, absence of emotional response, and reduction in awareness of his or her surroundings. So for this subtype, all the previously mentioned PTSD symptoms have to be present, but also high dissociative symptoms such as derealization and or depersonalization, both of which we discussed earlier. Moving along from here, I would just like to talk a little bit about how to screen for childhood trauma. These are some of the general guidelines, and I realize that they've been actually developed in USA, so I have not looked into the screening and assessment for childhood trauma in Pakistani communities, but I think the basic idea is the same. So you may have to address the stress-related symptoms, determine if child is still living in a dangerous environment, so safety is the most important thing. Provide child with a genuinely safe setting, inform him or her about the nature and the limitations of confidentiality, since at least in USA, a child may disclose something that, like a sexual abuse, to the physician, hoping that nobody else would know. But I think that cannot, in order to keep the child safe, that level of confidentiality doesn't always apply. But this should be something that should be discussed with the child. It's important to understand the multiple perspectives of trauma. So the child's experience, the parents and the legal guardians, and so on, and anybody who's involved in the child's caretaking. One may consider self-report but also assessor-directed questions, and try to recognize the potential impact of both culture and developmental levels while obtaining trauma information from children. So all of the understanding of trauma and what can be trauma is really culturally influenced. So it has something to do, it has to be something that is not typically accepted and not a typical norm in that community. A lot of my fellows and residents really struggle with how to talk to a child about trauma. They often feel like they're actually imposing themselves on the child. So for that reason, I've just suggested a few questions. But the most important part is to actually use simple language, very calm tone in your voice, and try not to shy away from the topic, but maybe use the simple words that is easily understandable to the child, depending on the developmental age. So one may consider asking a child, has someone ever touched your body in a way that you didn't want them to, or know somebody whose body was touched in a unwelcomed way or an uncomfortable way. And regardless of whether say the yes or no, then I approach the idea. So first, it may be easier to imagine this happening to somebody else. Then it may be easier to address the question when it's maybe happening to them. Another screening question that you may think about is, has someone ever attacked you or tried to hurt you really badly? Have you ever been in a really bad accident, like a car accident or a fall or a fire? Have you ever known somebody who got really hurt or sick or even died? And these may be simple ways of actually just screening for potentially traumatic experiences. Moving along with screening, so the treatment for trauma is actually quite multimodal. It requires different disciplines. So I would like to just kind of help you have a basic idea of what the treatment for post-traumatic stress disorder should be. And so the number one thing is safety. Safety, safety, safety. Safety is the most important thing. It is difficult to address what are all the other symptoms are if the child is simply not safe. If a child has disclosed some sort of abuse or trauma to you, it is important to address, what environmental changes that can happen to remove that child from that unsafe environment, or how to keep that child in a safekeeping environment. So often I've had to inform a parent that, your child has disclosed that the uncle has inappropriately touched them. So, it's important this is where the confidentiality would probably be not at the priority, where I would have to disclose to the parent that it's important that that uncle is not in the environment, or that this child is never alone with that uncle, and so on, just to kind of show you an example. You may want to refer the child for therapy, and I'm going to discuss different types of therapy that may be available. But you may also want to consider medications. There's no one fixed medication for trauma. A lot of it depends on the comorbidity and the symptoms. But at the end of the day, antidepressant medications do help, and we can talk about that in a slide or two. The usage of medications for me depends on the severity of the symptoms and response to therapy. So how impaired the child is, if they're not able to make it to school, if they're not able to form appropriate relations with friends, if they're not able to be engaged in their learning, that is a sign of pretty severe symptoms. So I may consider medications plus therapy at that time. However, if the child is able to actually function for most of the time, but struggling with sleep, does have flashbacks, has nightmares, but at this point is pretty safe, then I may refer just for therapy, and then over time assess whether the therapy is working or not. If the child's symptoms are getting better, then I may consider just keeping with the therapy. If the child's symptoms are not getting better, then I may consider adding medications at a later time. At the end of the day, the goal of trauma-specific treatment, and I cannot emphasize this enough, is to increase the enhanced sense of safety and security. So a child who's felt helpless and powerless, it's important that they feel secure and safe in order for them to actually start addressing other aspects of trauma. It is important to provide support and skills to help non-offending caregivers cope effectively. Often parents, when they find out that their child has been abused or maltreated or bullied, they may actually feel as if they feel guilty about not being able to protect their child. But if they feel guilty and if they feel helpless, then the child will never begin to feel empowered. So it is important that we also provide support to the parent so they do not feel too guilty and too helpless so that they can start actually modeling experience of empowerment for the child. It is important to address the symptoms and post-traumatic behaviors. Since a child often feels helpless and powerless, part of the recovery from traumatic experiences to give a sense of mastery and control in life, helping them understand that not all of the blame goes to them, that some of the blame is just situational, especially when it's acute experience. Some of the blame may be the fact that the perpetrator, may have mental health issues. But again, not all of it has to do with them. So addressing the self-concept of the child. It's important to help the child restore the sense of trust. That only happens when there's a sense of safety and security. And helping the child develop a sense of perspective and distance regarding the trauma. These are some of the goals, and they can all be addressed in different ways. Again, treatment of trauma is multimodal. Since excuse me, since I mentioned therapy earlier, I just want you to know one of the evidence-based treatments for trauma is, or evidence-based therapy for trauma is trauma-focused cognitive behavioral therapy. So this is a cognitive behavioral therapy that has been modified just to focus on trauma. It's a short-term treatment, clinic-based, and it is focused on the child as well as the family. It is designed for children aged 3 to 18 suffering from traumatic stress symptoms resulting from exposure to abuse, neglect, domestic and community violence, and other forms of risk of harm. Children and parents are provided with knowledge and skills related to understanding and processing the trauma, managing their distress and thoughts, feelings, and behavior, and enhancing safety, parenting skills, and family communication. So often this talks a lot about the emotional regulation, addressing the avoidant behavior and sense of empowerment, and addressing the distorted memory that a child may have for the traumatic experience, and empowering the parent as well as the child. Because of the time limitations, I will not be able to go deeply into what trauma-focused CBT looks like, but I highly recommend that you look into Judith Cohen and Anthony Manarino's work. They're the ones who developed trauma-focused cognitive behavioral therapy, and it is a standard manual that can be accessed online, and from my understanding, it is actually free. Another evidence-based treatment for trauma is eye movement desensitization and reprocessing therapy, also referred to as EMDR. It involves recalling traumatic memories while focusing on personal strengths and engaging in distracting behaviors, such as lateral eye movements. So it tries to address the wiring of the trauma a little bit. It has been known to be pretty helpful, but it is only one part of a multimodal treatment. It has not been recommended as a standalone treatment. And as I mentioned, medications that can be considered for children with traumatized experiences. If they're experiencing anxiety and depression, antidepressants may be considered. Alpha-2 agonists can be considered, especially for preschoolers. If there's nightmares, alpha-2 agonists can be helpful, specifically prazosin, which has been well known for adult population, and there has been some data that has been shown to be positive for children as well. Since a lot of kids with trauma experience difficulty with sleep, one may consider giving them melatonin. Often I also give them trazodone because it's been pretty effective, but a low dosage. When it comes to agitation and behavioral issues, I think behavioral measures as well as symptomatic treatment to help them stay calm can be used. But again, I would use it cautiously. This is not only one treatment. There has to be a team of treatment providers that has to be set up that includes, helping parents understand how the trauma may be taking place in the child. So agitation may be a form of communication and a form of a protective measure rather than just being a problem child. And again, therapy and involvement of the school and other measures has to be suggested along with medications. I hope this has been helpful to you. I'm happy to answer any questions at this point.